All right, everybody. As promised, here is the conclusion of the advanced cardiac rhythms. The last thing that we have to talk about are heart blocks. And some people get a little crazy about heart blocks, but I promise they are not that bad. Okay, so let's work through these and see what happens. So there are a total of three. There's first degree, second degree, and third degree, but second degree has two. So I guess technically there are four different types of heart blocks. So let's start with our first degree heart block. We have P waves, we have QRSs. The only thing that is different is the PR interval is just long. That means there's some sort of delayed conduction from the atria to the ventricles. It's just a prolonged length of time. We know that the PR interval should be 3 to 5 little blocks, so that's 0.12 to 0.20 seconds. PR interval is just greater than 0.20 seconds. So the example I have shown you here, this is the P wave. There is a long or delayed conduction time from the atrial to the ventricles. Here they have measured it at 0.38 seconds. So that is just about right. And you see that happens every single time. If we had a longer strip, you would see it occurring frequently. So P wave, delayed QRS, T, P wave, delayed QRS, T, P wave, delayed. So that is your first degree heart block. Now, there are a couple of different reasons why people have first degree heart block, and typically it does not require any intervention or treatment from us. The most common one are athletes, particularly long distance runners. So people who do marathons, triathlons, and I forget some of the other ones, decathlons. There's a ton of endurance type athletes. They actually have first degree heart block. It is normal for them, it is not unusual for them. The other thing that you'll find in first degree heart blocks, and any of the heart blocks really, it's a much slower rate. So these are considered bradycardic rhythms. Another reason for a first degree heart block may be that your patient has experienced an inferior wall myocardial infarction. They've had mitral valve surgery. They've had some sort of infection like myocarditis or rheumatic fever. It could be from a high potassium level. So let's not forget those lovely electrolytes. And then, of course, we have the classic medications that cause all types of heart blocks. So you'll see these recurrent over the next couple of heart blocks, but it's our beta blockers, our calcium channel blockers, digoxin or digitalis, and amiodarone. And so, again, like I said, first degree heart block, most people have a slower heart rate, typically are not symptomatic, typically do not require treatment. We just go on about life. In fact, there are some instances where we want first degree heart block, and that would be like in our heart failure patients because we don't want to overwork the heart. So, a lot of times you will see these medications used in our heart failure patients, and they actually have first degree heart block. We're going to move on to second degree heart block type 1. This is also known as Winky-Bach. I'm assuming that is the scientist that founded it because I can't imagine any other reason to have a name such as Winky-Bach. The other name for it is Mobitz type 1. What happens here is the PR interval gets longer and longer and longer until a QRS complex drops. So the PR interval starts out relatively normal, gets longer and longer until all of a sudden the QRS just does not show up. Reversible heart block at the AV node. So again, this is an AV node misconduction or malconduction, however you want to say it. But we've shown you here. If we could see this first one right here, you would see it would probably mimic this one right here. And then the PR interval just gets longer and longer. And then all of a sudden we drop a QRS complex. Rinse and repeat. Shorter, middle, longer, drop. Shorter, middle, longer, drop. And so that just continues over and over and over again. If you were to run a very long strip, you would see this pattern continue to repeat itself over and over and over again. So again, some reasons why we might have second degree heart block type 1, again, those medications that I told you you would see again, there they are again. Also, the inferior wall myocardial infarction, myocarditis, and sometimes after cardiac surgery. Now, the interesting thing about cardiac surgery is over time, when those synapses heal and the patient heals from cardiac surgery, they will revert back to a normal heart rhythm or may even go back to a first degree heart block or just bradycardia. So it just depends on how fast the heart heals after surgery. Treatment, very rarely do we need to intervene here. Again, I talked about this in our second video of advanced EKGs, everything but heart blocks. If your patient is not symptomatic, don't worry about it. There's no rush. There's no fire to run to. So asymptomatic equals no treatment. If we have a symptomatic second degree heart block, we typically will give atropine. And again, these are bradycardic rhythms. They are relatively slow. So the atropine is just to help speed up the heart, simply because the heart block in itself is not bad. It's whether or not our body can perfuse having a heart block. So just remember that in the back of your head. This is all down to perfusion. If your patient is warm and pink and has a good blood pressure, those are all considered asymptomatic. We're going to move on to second degree heart block type 2. Now we're getting into some serious stuff and where we should be concerned. So we always have a P wave. The atria and the SA node always do what they're supposed to do. The difference is the QRS, sometimes it shows up and sometimes it does not show up. However, when the QRS does decide to come to the party, the PR interval is always the same. So you can see here there's a P wave without a QRS. P, QRS, P, QRS, P, QRS. The length of the PR interval is relatively the same between these beats. P, we dropped another beat, okay? And so that pattern kind of repeats over and over again. Again, I don't really like these for 6-second strips because you really need to see a pattern of what this patient is doing. So for this patient, I would probably run a 30-second strip, so about 5 of these in a row, just to kind of see where my patient falls, because it's all about patterns. Okay, we have to monitor the patterns. What happens here is there is some sort of conduction problem at the bundle of His and the Purkinje fibers. So the AV node does its thing, the SA node does its thing some of the time, but not all of the time. And most of the time, the communication between the atria and the ventricles are relatively stable, but it doesn't always happen. So in other words, the AV node does not always fire like it's supposed to. So what are the reasons why our patient would have a second degree type 2? Well, they could have an anterior wall myocardial infarction. They could have some sort of fibrosis, disease of the heart. Again, could have had cardiac surgery, inflammatory diseases such as rheumatic fever, myocarditis, Lyme's disease, autoimmune such as lupus, or just general myocardial disease such as sarcoidosis and hemochromatosis, which is excess iron in the bloodstream. Also, that lovely hyperkalemia. You guys know about potassium. The heart really is sensitive to potassium. And then, of course, those medications that we've talked about time and time again. So, in other words, sometimes we encourage heart blocks, but there are other times where the diseased heart causes a heart block. So, how do we treat this? This type 2, second degree type 2, is most likely to go to a third degree heart block. Our other ones, first degree heart block, second degree type 1, typically not a problem. It's not until we get to type 2 and we get to third degree or complete heart block that we actually have to start worrying about things. So this one will most likely progress to third degree heart block if we do not fix it. We have to treat the cause. So if we have some sort of infectious cause, treat the infection. If you treat the infection, you treat the heart block. It's simply that easy. There are other reasons why, if we go back really fast to our reasons, fibrosis, we're probably not going to get over that. An anterior wall myocardial infarction, once that heart dies, we can't get that back. Those are things that we cannot treat. If that is the case and they advance to second degree type 2, they will require pacing. Okay, so they need some sort of pacing device. The other thing too is if we're treating an infection, we can actually do temporary pacing where we put pads on the outside of the chest that are synchronized to do synchronized pacing for the patient with a external defibrillator monitor. We do that until they are stable. Once these patients become stable, if we've treated the heart block appropriately and it reverts back to a normal rhythm, we take the pacer pads off and life goes on. However, if this is a permanent situation, the patients will then proceed to a cardiac surgery where they have a pacer implanted. And I'm going to talk a little bit more about that on third degree heart block, but this is essentially what it looks like. I'm going to walk you through that here in just a minute. Third degree heart block is called complete heart block. This is where our P's and our QRS's, they're not even synced. The P wave comes whenever it wants to. The QRS shows up whenever it wants to. There is a complete disconnection between the SA node and the AV node. So no communication whatsoever. The heart is simply doing whatever the hell it wants, whenever it wants. And so what you see here is you see these P waves. And you could even have right here, the reason why this looks a little different, this T wave is awfully peaked and high, and it's probably a heart attack, but that's not the point of the conversation here. This one looks a little funny, how it's got like two peaks to it. That's because a P wave has arrived right in the middle of that T wave. P wave, P wave. And then you see the R, the R, the R, the R. So totally no communication whatsoever. This is bad. This is not a good thing, okay? Again, causes things that we cannot reverse would be things of an inferior wall myocardial infarction, the medications we may have to back off on, or they have become toxic in nature and we have to change up the medications. But again, you see those lovely little same culprits here, beta blockers, calcium channel blockers, and lovely digoxin. It can also be a degeneration of the conduction system. And again, this could be infections, rheumatic fever, sarcoidosis. Things like sarcoidosis and those autoimmune disorders that we talked about, those are not reversible, but some infections can be. I actually took care of a man that was about 30 years old. Yeah, I think he was like 38 years old. He had third degree heart block simply from sepsis. Once we clear his sepsis out, we put him on continuous renal replacement therapy, or CRRT, which is continuous dialysis. And as soon as we cleared up the infection, we took him off the pacer and he was fine, which leads me to what are we going to do? Number one, we treat the cause. If it's an infection, treat the infection, put them on antibiotics, clear out the sepsis from their blood, whatever the case may be. We can temporarily pace them. Again, that's that external pacing with the pads on the chest, the external defibrillator that has the pacing mode placed on this patient until they become stable, or we may have to implant a permanent pacer device. Now, some of you guys have probably seen this from your patient. You can see these on chest x-rays. They appear as a little box underneath the left chest wall, and they have electrodes. These electrodes go through this major vessel and they get implanted down here in the ventricles, usually attached to the Purkinje fibers at some point, and that stimulates the electricity. Because in case you haven't noticed, all of these heart blocks, the SA node is just fine. The SA node, which is the pacemaker, typically does just fine. You see P waves in every single one of these rhythms. It's the QRS that gets off. And so a lot of times you will find that these patients need a ventricular pacer. So these are implanted into the ventricles of the heart. This machine is smart enough to know the atria have contracted. Now it's time for the QRSs, okay? There are situations where your patients are biphasic paced. That means they have electrodes on the atria of the heart as well as the ventricles, because neither one of those are doing very good. This is typically advanced heart failure, which is not within the scope of this particular conversation. The last thing that I want to just kind of say, and I meant to do a slide on this and I forgot to do it, but the way I learned heart blocks was through a marriage. So the P is technically the wife, even though I know that's kind of out of use anymore because we have gender neutral and we have same-sex marriages, but just bear with me for the sake of tradition here. Your P wave is your wife and your QRS complex is your husband. And so in first, well, let me back up. In normal sinus rhythm, this is a happy marriage. We have a P and the QRS comes home every night, just like he's supposed to. All right. So the wife is at home and the QRS comes all the time, every time, same time, in an appropriate time, gets home from work at 5 p.m. every night. In first degree heart block, the husband is late every single night. He shows up to home, but he is late every single night. So he's supposed to be at home from work before 6 p.m. or before 5 p.m. He comes home at 6 or 7 or 8, but he always comes home. He just happens to be late. When it comes to second degree heart block, we have the wife again, the P wave is always home, always doing her job. She's always where she's supposed to be. But the QRS, her husband, comes home later and later and later until he doesn't come home at all. So this is where we talk about the longer and longer until it drops. Short, long, longer drops. So P wave's always home. QRS comes home later and later until he doesn't come home at all. Second degree type 2. The P wave is always home, so the wife is always home waiting for the husband. Sometimes he comes home, sometimes he don't come home, but when he comes home, he's home every night like he's supposed to. So the wife is sitting at home, he decides to go to the strip club, goes out with his mistress, whatever the case may be, he doesn't come home. But then for the next 3 nights, because he knows she's mad at him, he comes home like he's supposed to. So Monday, Tuesday, Wednesday, he comes home like he's supposed to. Oh, Thursday hits, he's gone again. Okay, so sometimes he shows up and sometimes he doesn't come home at all. And then when it comes to the third degree heart block, literally the wife is doing her own thing and the husband's doing their own thing. And the only way to get this marriage back together is to have a counselor, which is also called the pacemaker. So he brings them back together to make them in harmony again. I know, a cheesy little way to remember it, but that's how I always learned heart degree, this several degrees of heart block, and it's always worked. So I've always recognized it. Anyways, that's all I have. If you have any questions, you know how to find me. Otherwise, I hope you enjoyed this video of third degree heart block, and I will talk to you guys later.